I agree. This has to be.
Yeah.
All right, everyone, thank you so much for coming. So this is another event of our Global Health Week. We're all looking forward to this. I just want to introduce our moderator, Allison Portnoy. She's a former PhD student in the department, was spending some time with us for the postdoc, but started in July. She just accepted a position as an assistant professor at BU. Yay! So nobody better than her to lead this discussion because she's an expert on vaccines and her role is to challenge those two professors. So over to you.
All right, thanks so much for that introduction. Okay, so just to set the stage for where we're at today. So despite technological advancement in vaccine manufacturing and cold chain delivery, I think we have all experienced that a pandemic creates substantial obstacles in meeting the global need for prevention and treatment. So in the case of the COVID-19 pandemic, a global distribution network was established called COVAX that was intended to provide access to low and middle income countries for what we know was a very limited supply of vaccines. The initial goal of COVAX was for each country to be able to procure enough vaccine doses to cover 20% of the population. So the same 20% in all countries before allocating any additional doses to other countries. So first obstacle, the US and China did not buy in. Second obstacle, without that buy-in, very difficult to secure funding. Next obstacle, without funding, very difficult to actually establish these negotiations with high-income countries and with vaccine manufacturers. And then finally, there was a reliance on the Serum Institute of India as the primary vaccine manufacturer for the distribution network. When India was really hit hard by the pandemic in 2021, Serum Institute of India had to focus on domestic distribution, which meant that COVAX fell short of its target goals. So today, we want to talk about whether globally determined principles for allocating a limited supply of vaccines can work through the legacy of the COVAX facility. And our two speakers today, Dr. Muhammad Pate and Professor Richard Cash, will take what I think you will find to be interesting positions on both sides of this debate. And first, I would like to turn it over to Dr. Pate.
Well, thank you. Thank you very much for that introduction of the issue today. I'm going to argue that globally determined principles for allocation of limited vaccines actually do work. And from the vantage point of the experience we've had in the pandemic, but even outside the pandemic. And just to mention sort of my conflict, I was involved in the design of the Act A, of which COVAX was a pillar. So that's just to disclose it to you all. So in crisis of global health nature, we've always seen this tendency for products to be available in global north, wealthier countries first, before people in the southern part of the world and the poorer people. We've seen this with HIV. We saw that with pandemic flu, with the Tamiflu in 2009. And when outbreaks like Ebola, where you have a vaccine that is limited in terms of the stockpile, or even potentially Marburg, where there is no vaccine, but there could be one, or COVID as of 2020, there was no vaccine and the world was unsure whether there was going to be a vaccine available. Manufacturing capacity wasn't there. So in such circumstances, initially, shortage of vaccines is inevitable. The supply will be limited relative to the demand when you have a major crisis. That's what we had. And it changed over time, 3 years, 18 billion doses, but that's 3 years for that to be the case. The question of who gets what, when, and how is so vital, I think, in terms of our thinking. And so to ask what are the principles that should guide the allocation, it's a reasonable proposition. And what objectives are we trying to achieve from a public health standpoint in terms of minimizing loss of life, minimizing the harm, but also from a justice perspective. Otherwise, everyone will be for his or herself. And the allocation principles that were defined were really for inter-country allocation of vaccines, with allowance for contextualization of the intra-country allocation of vaccines. I think there is a sound ethical basis to say that we shouldn't allow it to be free for all. But otherwise, it will be, some will take 3-4 years before they get access to the vaccines. Moreover, the entire global community, through the WHO Constitution, as well as through the World Health Assembly in 2020, passed a resolution asking for fair allocation, fair access to everyone, but also fair distribution of commodities, not only vaccines, but other essential products in the pandemic. And the principles that were articulated, who will disagree with those? Solidarity, that we have a major crisis, let's come together and solve them. That there should be accountability. Those are the principles that govern the allocation framework. The transparency in how it's done, rather than folks do side deals with corporations. Responsiveness to public health needs, as we knew them. Equity and fairness, ensuring that people are not left behind who need it the most. Affordability, making sure that there's no price gouging. We're talking about vaccines, but you will recall early in 2020, masks went almost 20-fold, 30-fold, because they are not available. So ensuring that in fact there is transparency and that the products are affordable and that folks collaborate globally in making sure that everyone gets it. And that in fact the regulatory standards are not weakened for one part of the world or the other, because that's another issue. Because you could have a product but manufactured in poor regulatory context, whereby poor regulated products go to one market and better regulated products, let's say by anyway, go to another market. So you have an appetite. So based on that, a globally determined set of allocation principles on how to was necessary. But how did it unfold? And that's where the caveat is important. It didn't unfold as completely expected. I think primitive sort of instincts, I would say, sort of overtaken. The me first in certain countries ensured that in fact countries went and purchased multiple folds of what they needed and hoarded them. The mechanism for the poorest of the world basically was relegated to the very end. Political leaders chose their countries first, and they did not buy into a globally coordinated mechanism so that everyone would be protected. The 20% was really computed on the basis of what we knew about COVID epidemiology. That frontline health workers and service providers are first, estimated about 3% of populations, 16% those who are 65 years and more. So if you add that, that's 20%. So if you go by that, and you have 2 billion doses in 2021, you will provide that basis for everyone, and then incrementally, based on country needs, based on absorptive capacity, additional doses can be made available. And as we see, 18 billion doses have been manufactured over the last 3 years. So everyone would have, in a way, incrementally gotten what they needed, but there wouldn't have been the huge distortions that we've seen in access to COVID-19 vaccines. So I'm sure you'll agree with me that this globally determined allocation principles, where you have shortage, a major health crisis, actually makes sense. So I will stop here, but we can have a further conversation on it. Over to you, Allison.
Great, thanks so much. All right, Mr. Cash, your response?
Well, I can't argue with any of these goals and objectives. I think they're self-evident. I think my take on this is that the implementation and the way these things are carried out, once you set up a standard of 20%, or the WHO said at the beginning, 70% of the world should be immunized, I think were absurd in a way and actually distorted the situation. And what do I mean by that? I think that this idea is that every country, and Vikram Patel and I wrote an article back in May, I think, of 2020, where we argued that, first of all, this was a and I would stand by this, that this was a pandemic primarily affecting wealthier countries, not the poorest countries. If you look at mortality rates, for example, and we saw this actually quite early on, the mortality was much higher in Western Europe, the United States, and parts of Latin America. The countries with far and away the lowest mortalities were in sub-Saharan Africa. 1/100th or even less of the mortality that was seen in the West. So to say that equity, we're all going to get the same amount, I think distorted the situation. And because of that, we actually created this sense of inequity. I think that there was more than enough vaccine to impact on all of those individuals who needed it. The problem with setting up international standards is that that need was not taken into consideration of each and every country. Now, let me expand on that. From very early on in this pandemic, we knew that this was a disease that affected primarily people of my cohort, that is, individuals over 65. In Massachusetts, over 85% of the deaths were in people over 60 years of age. Okay, so you have huge differences in demography, and the most important factor in determining mortality was the age of the population. And so why should countries with very, very different age structures receive the same amount? Doesn't make any sense to me. In the Western countries, the elderly are often warehoused in what I would consider slums for the elderly, old age homes. Okay, grouped together. A number of the sub-Saharan African countries that I'm familiar with, the number of old age homes are minuscule. People live with families. They don't live in these kinds of situations. Rohingya refugee camps, which many of you may know about, is about 900,000 people. 900,000 people. How many deaths occurred during the COVID epidemic among those 900,000 people directly from COVID? Actually, it's under 50. Under 50 people are recorded as having died from COVID. So why would you treat that group? And we knew this early on. We knew this was a disease of older people, not of young people, not of your cohort. There are some deaths, but it's not certainly worth causing a global lockdown to prevent that from happening. So my objection to the global standard issues is, one, it goes against local autonomy. A number of countries were turning back and they said, we don't need the vaccine. Why didn't they need it? Because it costs 2 to 3 times the cost of the vaccine to deliver the vaccine. Okay, they had other priorities. Now, if somebody said, here's the money, you do what you want with it, they would have said, well, actually, we would like to use it for measles vaccine or something else. But when you set up a mandated number, or 20% or 10%, you create a situation that, in my view, leads to global disparities, because then the wealthier countries are going to hoard it. Secondly, it bypasses local epidemiology and local autonomy. And thirdly, I believe it causes some of the distortions that we saw early on. And we need to, of course, separate early in the pandemic to later on, as Muhammad said, because things change dramatically. The problem is in a pandemic, you don't have a lot of time to work with. You're caught in a bind. And we may be in another situation coming up with the H5N1 flu virus, which is hasn't jumped yet to human populations, but that possibility always exists. And you think we had a crisis with COVID? That'll be nothing compared to H5N1 if it does break through. So That's my take.
Thank you. So I think we can, unfortunately, probably very accurately note that there is a high likelihood of a future pandemic, whether it is influenza or otherwise. So I'm gonna ask our speakers a couple questions to get us started, and then we will be turning it over to audience participation. So please get your questions ready. So the issue of hoarding now has come up from both speakers. So first, we on the one side, the idea that without preemption for vaccine distribution access, you would result in hoarding of wealthier nations buying out and hoarding vaccine doses. Now, we also just heard that there's the potential for by creating such a globally determined principles and a global distribution network, you are incentivizing hoarding. So let me ask both speakers, so when we have this, in the case of a future pandemic, and we know that there will be a limited supply of vaccine doses, what steps could actually be taken to prevent wealthier countries with access from buying out and hoarding doses?
So I think let me just make a few reflections on what we just stated. I think the early 2020, in the context of this pandemic, we had a new virus that we didn't know. We didn't know how it was transmitted. Initially, there are many questions, huge uncertainties around the virus and the direction it was going to go, from Wuhan to Italy, Europe, to the United States. Huge uncertainties. And as that was unfolding, we also know that even diagnostics, as a reflection of where we were in the global system, we're very challenged in that. And so try to avoid making the mistake of inferring that the absence of evidence is evidence of absence. The fact that in the early stages of the pandemic, you see parts of the world where there were no cases, no confirmed cases, no confirmed deaths, doesn't mean there were no confirmed cases, because the PCR in Africa was started in March 2020, and very limited testing, mostly in travelers. So the epidemiology of COVID-19 in many parts of the world, I think we're still beginning to understand that. And there were studies that showed in Zambia more than 100-fold from serosurveillance, from confirmed cases and the actual numbers of infection. But you wouldn't be able to know that and gauge the burden of disease. So inferring sort of the distribution by virtue of that. Yes, it's possible the demography played a role, but we don't know. There are lots that we still don't know because this is a novel pathogen. The second point I would like to make is that, in fact, when you have such uncertainty, we didn't know that there was going to be a vaccine. By May, June, spike protein, whether there will be a coronavirus vaccine was a big question. There's never been one. So countries went and approached it from every country getting a pool of vaccines and placing bets because they didn't know which vaccine would work. Now, there was a global mechanism, which is the COVAX, which was designed as a global mechanism that ensures access for everyone, particularly for the poorest and vulnerable. But the political consensus was like it. We're in a world where some countries are saying me first or me alone, and potentially could weaponize access to the vaccines to the detriment of others. Because if you immunize all your people and your economy is up, everybody else is really on their own. So that's the context where we are. How do we mitigate the hoarding when you have highly lethal, highly transmissible pathogen in the future? It's likely, the flu could be. And if that happens, we will be in a very deep mess if global leadership is not in such a way that buys into this idea of global cooperation to deal with common challenges for the world, if everyone sort of goes on their nationalistic path. And that is a big question, whether the political leaders will be aligned at that point to say, look, we've got a problem, let's come together and let's solve for the global commons. If we don't do that, you will inevitably see some of those hoarding security games that nations will play, hiding their stockpiles and all of that. From a practical standpoint, a mechanism like COVAX, what is the alternative? You can criticize its failings here and there, but there's been no counterfactual. What would have been the case without a mechanism for many of the poor countries like where I come from. So in the future, hopefully, we'll learn the lesson and say, look, when you make those deals and make those deals such that the poor countries also get their doses at the same time with those who are able to pay for it. Put mechanisms to ensure transparency, even on the pricing. The vaccines were priced differently in different countries. And the transparency around the pricing, I don't think we still have a full understanding of how those were arrived at. So those mechanisms could help improve the global access. And we don't know where the next pandemic is going to come from, but I think we'll all be better protected if we have those common mechanisms with adaptations and contextualization based on epidemiology, based on target product profiles, and based on the goals that we're trying to accomplish.
Thank you.
I think to expect countries not to hoard is fantasy. Which politician is going to say, well, you know, we're not going to give it to you guys, we're going to give it to the Nigerians? Well, he could do that or she can do that. They're not going to be in office very long. So I think that the notion that you're going to avoid some degree of hoarding by setting up this international, everybody's going to get 20% or 30%, I think is dreaming. I think what you need to do is to have a better idea of how much do you really need. How much of the coronavirus vaccine did we really need? We needed far, far less than people were predicting. Unfortunately, some of the early modeling, we can get into that at another time, from Imperial College and others, was so wildly off base as to, it was absurd. They were predicting millions and millions of deaths, which came out to a few thousand. They were that far off. I think what we need to do is to have a better idea of what is actually taking place at the local level. So we really know what the needs are, not what the needs. I differ a bit with Muhammad on this. I think we knew fairly early on what the pattern of this was, that it was a disease that killed. And that's what we have to remember. What was the purpose of the vaccine in the first place? It was to prevent deaths. It was not to prevent the spread of this disease. And unfortunately, the narrative got changed. The narrative became, well, we're trying to stamp out the epidemic. We're trying to limit the number of cases. That's not what the vaccine was meant to do. The vaccine was meant to stop deaths. And it did a very, very good job of it. It didn't do a very good job of limiting spread because that's what it was. It wasn't designed for that. It wasn't designed for that in the first place. And unfortunately, we conflated the amount of vaccines that we needed because people got into this, well, we're trying to prevent the spread of this disease. That's not what the vaccine was meant to do. So I think we need a more honest and forthright look at what the strategies are, what makes sense and what doesn't make sense. We could have, the amount of vaccine that we needed to prevent deaths was far, far, far less than what we needed to prevent spread, which has continued on despite the vaccines in different places of the world, different kinds. And what is absolutely fascinating about this disease, of course, and with every infectious disease that will come along, is how it plays out very, very differently depending on where you are in the world. Japan has the world's oldest population, by far. By far. They have one of the lowest death rates from COVID. We could get into a whole discussion of why that's the case. The United States, which had, you know, we're the Athens on the hill when it comes to providing high quality healthcare, has had one of the highest. Okay, that is the role of the healthcare system in preventing deaths was really limited. So what we need to do is to, and Nigeria Nigeria reports one of the lowest death rates in the world. Now, this could be underreporting, who knows what, but even if it's underreported by a factor of 50 or 100, it's still very, very, very low. And good for you. Excellent. But it plays itself out very, very differently depending on the political, the social, the economic, and a whole variety of other factors which we've come to recognize. So to come up with a single standard, I think we created the shortage of vaccine by using a narrative that, in my view, didn't make sense.
All right, so based on where we're already at with time, I would like to go ahead and open it up to the audience for questions. Yes, please. Could you stand up and introduce yourself?
Hello everyone, my name is Temi Umi Akimulea. I'm a first year Master of Science student in Global Health. And my question is for Professor Cash. I think you both had compelling arguments. And I just want to ask, with infectious diseases, we know that all of us are not safe unless everyone is. And infections know no bounds, really. And so I just want to ask you, when you proposed your argument, you spoke about the demographic changes across borders. But I think one thing that I did not find, which I want to bring to light, is the epidemiologic transition across countries, especially the developing countries. Cardiovascular diseases are the leading cause of mortality in a lot of developing countries in sub-Saharan Africa, and this wasn't the case 20 years ago. And we know that age is not the only factor that is contributing to mortality in COVID-19 cases. We also have the presence of comorbidities. And I just want to ask that in light of this, would you say that local autonomy is still the way to go in ensuring vaccine equity?
Well, let me take a bunch of those things. First of all, I want to object to the word, no one is safe unless everyone's safe. I think that's a good bumper sticker, but I don't think that's true. Yeah, it's a good bumper sticker. Put it out there and everybody uses it. But from a public health perspective, I just don't think that that's the case. You're safe depending upon the environment and the situation that you create, and not because somebody in New York City has the disease, then we're all equally vulnerable. No, I don't buy that. Now, you asked the question. Repeat the last question that you.
So my question is, should we still allow countries to have local autonomy, regardless of what is happening in other countries?
Well, the question is, do we allow each country to have local autonomy? Well, in fact, we do. Do we really want to? Let's take polio. Okay. Should we? And polio, we know it exists in Pakistan, Afghanistan, a few other places. It was in northern Nigeria. It's no longer there, supposedly. Are we going to condemn those countries and put travel bans on those countries because they have polio? Do we want a world like that? I don't think so. I think we want to give those countries as much assistance as they require, as they want. But I don't think that we ought to start banning countries from banning their citizens from travel. I remember when they had a cholera outbreak in Haiti some years ago, and it was traced to Nepali soldiers who were working for the United Nations. There were some people who said, well, we ought to, people from Nepal shouldn't be allowed to travel to places unless they have a negative cholera test. And I thought, well, we really want to go that direction? We really want to ask everybody in Bangladesh, which is endemic for cholera, to show a travel document that claims that they are negative on a test before they left the country? Or do we want to make sure that Haiti has a water and sanitation system where people aren't drinking sewage? And that's what they were. They were drinking sewage and they were all getting cholera. Right next door in Dominican Republic, they didn't have it. Cuba didn't have it. Well, that's because they have good water and sanitation. So the issue really is, instead of banning people from traveling the world, to ensure that the conditions that you have locally are such that you will prevent the spread of or the introduction of a particular condition. Now, it's particularly difficult, of course, when we're dealing with respiratory diseases, because we're all sharing this common space. Somebody right here, you could actually be spreading something to the rest of us. Okay, so that's my take on your question. Thank you.
So it's quite fascinating to just sort of hear the exchange, and it just brings to mind sort of the debates almost 200 years ago in international health, which started really from cholera outbreaks in Asia coming to Europe, and the idea of an international health agency. And primarily around quarantine, port security, that's sort of the angle before WHO. And the debate in Europe, and many of you study history and you know that, and Richard, you know this very well, are miasmatic theory and contagion theory. Miasmatic theory is sort of, the firms preferred that, because the contagion theory, well, cholera is not a contagion, let's sort of not close the borders because it'll affect trade and all of that. And it's still that debate that is still unfolding. That's just a side comment to this. I think it's the globally determined principles that we're speaking about make room for country contextualization within countries. It's not to do with intra-country allocation. Those principles that were laid out were principles to guide how countries get access to these products based on past experience, based on the huge uncertainties, and the fact that we have a pandemic with huge uncertainty. It's better to take risks than not to take risk. It's better to produce more and waste it in a way than to not produce and be slammed by a highly lethal, highly transmissible pathogen. In the case of COVID, 18 billion doses have been produced in the last 3 years. 12 billion had been administered, so maybe a few billions will be wasted. That's a lot of money to waste, but we could have saved lives by just having that. That's a risk that you take in anticipating a major outbreak and a pandemic, and ensuring that you don't deprive a part of the world. Imagine if you actually just have it one. Let's say African countries don't have access to vaccines. We know this virus mutates, it evolves. Vaccines became available, Omicron came, whole story changed. And the mutations could continue to unfold. What would it mean if it escapes even the vaccines in the north? So the fair allocation and access for everyone in a way is getting at trying to protect everyone. At least we're in this global commons dealing with a pandemic. If there's one thing that interconnects us, is a challenge like a pandemic. And so going the route of every country by itself, to me, sounds like not a very winning strategy for the long run. But Richard maybe disagrees. Oh, yeah.
I certainly
So,
again, I'm worried about a one size fits all, and when you go down that way, I've seen too many instances where it's clear that one size doesn't fit all, and that local autonomy, and after all, the world is getting far better in terms of developing every country its own cadre of epidemiologists and lab scientists and so on. We're at a very different place than we were 50 years ago or 30 years ago. So that now, and whether it's sub-Saharan Africa or South Asia or wherever you're talking about, the capacity is much, much better than it used to be, which gives, in my view, a sense of autonomy. The argument for greater autonomy is stronger.
Let me bring you back to the audience. Yes, please stand and introduce yourself.
Hello everyone, I'm Hailu, second year DRPH. My question is for Professor Pate. As moderator earlier said, one of the challenge had been the buy-in from the global economic and political giants such as America and China. how can we do better, like setting this globally determined principle and increasing the buy-in from such giants, having a significant influence in the implementation of this. And if we are not also capable of doing those in the global agenda setting environments, how is it helpful to kind of push these globally determined principles?
It's a tough one, and that's not really to do with the public health sort of part of this. I think it's more to do with the idea of multilateralism in the world that we are. What kind of multilateralism should we have? And do we believe in that? 70 years in the sort of this new order that we have had around the UN, WHO, and cooperation around nations, is it the way to go? In COVID, and by mid-May 2020, we knew that the United States had threatened to pull out of WHO. It was going on the path of Operation Warp Speed and was pledging $50 to $100 billion to immunize 300 million Americans, regardless of what happens in the rest of the world. That is an ideological direction that it was going, and that's a global leader. So that has changed since the change in administration. And in many countries, you also see that move towards nationalism. And I don't think we have the answer yet as to whether the multilateral sort of cooperation that we have been used to over the last 20, 30, 40 years will remain, especially what's going on in Europe at the moment. Perhaps we may see a different model where we have more federated multilateralism with regional blocs organizing themselves, with regional blocs also taking an active role to organize and solve their issues that are common to them, with the nation states in there as well, but in coordination with those that are like-minded in the global state. So it's a political question, and I really don't have the answer. Ideally, we should all be in this together, and we should take care of the global commons that we have, and whether it's pandemic or climate change or something else that affects all of us. But I'm not sure that that's where the political leaders are. So that's just my take.
I quite agree that it has become increasingly a political issue. In fact, that's what happened with COVID. It got very, very highly politicized. And if you take one position, you're this, and you take another position, you're that. It's really it's been very disheartening to see this. I guess we as a collective here want to return to the science of the situation. Look at science is science, and it's not a Republican or a Democrat or conservative or liberal or what have you. Ideally, that's the way we ought to go, and I guess that's maybe what I'm arguing for, that the science tells us that needs are different in different places, demands are different in different places, and that we should respect that. But by the same token, these things got, this distribution of the vaccine got highly politicized and was used as a political tool. Whether I give you free vaccine because you're with me, or I charge you more because you're not with me, becomes extremely contentious. We're gonna forget all about that, I'm sure. I'm sure that a year or two from now, people will forget all of those political battles that took place on who gets what and who doesn't get what. But unfortunately, that's what happened.
Can I just a quick addition? I recently saw Shen is not here. They wrote a paper recently in BMG Global Health. Really use quantitative methods to look at how donor countries allocated vaccines linked to whether the needs of the country versus the economic and political interest of the countries, and they looked at also the channels that they followed. What I took away from that is really some good insights that this globally coordinated mechanism, including COVAX, where countries follow through those channels to donate vaccines, mitigated the tendency towards nationalistic interests than if they had gone bilaterally. I think that paper is worthwhile. Shen is not here, so the folks can look it up. I think it's a very good,
And the lead author was?
is,
We'll,
I don't want to
we'll try to
mispronounce.
find it.
I'll send it to you, I'll send it around, yeah. Yeah.
Yes, please stand and introduce yourself.
My name is Celine Manga. I am coming from Peru. I am at the Chemi Programming International Health Fellow in this department. The COVID pandemic in Peru Peru has the highest mortality rate per million worldwide. And talking about the COVAX, in certain moment in the pandemic in Peru, we need 60 million of doses, and the COVAX has created the expectancy of giving us some solutions, and we lost the life of 250,000 of Peruvians waiting for this help, and at the end, COVAX has assigned to Peru 200,000 doses, individual doses. There is any mechanism of accountability over COVAX through this?
Easy one, that's it.
Yes, that's a very good question. Thank you for that. I think it's well, COVAX, first of all, by end of 2020, raised only $6 billion. It took until the end of that December when the Biden administration had won its election for full commitment of just 10 billion. When countries had spent 12 trillion in stimulus, when countries had made deals running into billions of dollars, which shows you that COVAX started with a disadvantage because of the political context that it was constructed. So it had to go in line to make the deals with the pharma industry, which had already committed to major countries, so that it was in line. You can list all the top countries that had already bought at prices that have not been disclosed, huge amounts of doses, multiple folds for their populations, and the precise effort that was put into COVAX to guarantee countries like Peru have the doses early on, the 20%, could not be realized. So it's unfortunate that that has happened, and I think it's a major lesson that I hope the entities that have managed COVAX have also taken on board. So accountability, I think that's something to think about, but I think it's an important lesson to be learned. Now, 85 countries went through COVAX, but also had their bilateral deals, by the way. So there are many countries who subscribed to COVAX, but also signed their own bilateral deals with the companies. And remember, there were proliferation of, there were at least 9, 10, 11 sort of vaccine producers. There were Russian vaccine, Chinese vaccine, other vaccines. And some of those things were happening in a very untransparent manner. So it was difficult to sort of know who is dealing with who at what price and what delivery, what time. There was a lag period of time. Because the globally coordinated mechanism that was envisioned was COVAX was not allowed to take hold, because the politicians in some of the bigger countries just didn't feel that it made sense for them. That's why having global cooperation mindset will begin to minimize the risk that we see repeats of things that happen in Peru, unfortunate as they may be.
It's interesting to note that one of the big defaulters in terms of providing the vaccine was one of the countries was India. Okay, India pulled out, said, hey, we're doing our citizen. And a lot of the calls for equity are saying, let's put the manufacturing facilities in some of those countries. Well, that's cool, as long as the country decides that they're going to actually distribute the drugs. Okay, India, the major producer, said, no, we got our own 1.3 billion people, we're going to vaccinate them first. So you want to think about, is it really going to help if we put plants all over the place? If in those countries they decide that they're going to keep the vaccine, which is exactly what happened. Huh?
I do feel the need to clarify that that India made the deal when it had not yet experienced a significant outbreak and chose to reallocate to domestic distribution following a significant outbreak. But still point well taken in terms of if anybody else would like to ask a question about local vaccine manufacturing capacity, I will put that to you, but next question. Yes, in the back there, yes.
Hi, June, first year DRPH student. My question is about, again, the accountability. We forgot to mention the pharmaceutical company. I think they are the demands, they are the supply side who actually manipulate all the principles. And how, first question is like, can we even possible to hold them accountable? If not, what leverage that we have to hold them accountable? Of course, we can be pessimistic. No, they are the market economy works by themselves. But if we have some leverage at the multilateral system, what could be the source of leverage that we can actually hold them accountable? Thank you.
Well, as I understand in the Indian situation, it was a private company, but the government said, sorry, you can't sell it elsewhere. You're in India and you're working in India and we control your license, and so you're gonna supply us first, right? Is that what they said?
Part of it, yes.
So I suppose the government has a way of reining in the private sector, or as in the case of HIV drugs, you found a supplier and a producer who could produce it at an Indian company, Cipla, that produced it at a price that drove the market down. So, but I am no expert on this or TRIPS or any of these things, so I'll turn to my colleagues.
So, I mean, the Indian example is a very good one, but I could also sort of relate to sort of ventilators in the early phases of the pandemic. I was part of a conversation. We give a country in Africa some resources, concessional financing. They bought ventilators, 250 of them from the United States, because that's the only place they were available. Then limits. They've paid for them. Ventilators are available. But you remember Defense Production Act and the US sort of blocked. That's an issue. That's one of the key lessons, the sort of nationalistic tendency that countries can refuse to make those concessions and refuse to allow, that's a lesson. So decentralized medical industrialization, I think, should be one of the lessons that we emerge out of this, whereby regions of the world, smaller countries also contribute in a way that makes sense for the product that they are developing, so that there is diversity in sources of those products, whether they are masks, whether they are ventilators, whether they are health commodities or vaccines. Accountability for firms, they're private companies. They're subject to national laws where they're registered, they are taxed, and they can be, if they renege on contracts. What is key is a lack of transparency in the contract they signed to purchase. When this whole thing gets examined, and when you know the prices, many countries will realize that they pay several fold the prices that their neighbors pay. There are other terms. Advantage of a mechanism like COVAX is it also sort of, in a way, harmonize some of the complexities to make access easier, like the regulatory side, so that it's streamlined through with WHO. It was also things like indemnification, the liability, because all these products were administered under emergency use authorization. They are not licensed. So that's a big risk for the companies, and they had indemnification because of the emergency situation that we had in. So having a common platform allowed those issues to be solved. Things like labeling. How do you label different vaccines with different doses, different formulations? If everyone just labels their own way, and you can imagine there's issues of pharmacovigilance and monitoring, all of that. Those are global common issues that cannot be tackled farm by farm or country by country. And we need to come together to be able to do that. And that's what COVAX was set out to do. So I think in some ways it succeeded, but there are some other ways, in my view, because of the political context within which it was constructed. The principles were there, but there's the implementation, like we just said, we're not really close.
Jessica, have any questions come in on the Zoom?
Yeah, there's 3 people who raised their hand. Daniel Wickler's first. I don't know if we can hear him through the Zoom webinar.
Maybe you can read the question.
Yeah, could we ask them if You can just type in their question in the
Oh,
Q&A. 'cause
yes,
Okay,
okay, we'll
thank
come
you
back to
very
that,
Yeah.
but yes, please ask them to type their question, yes, all the way in the back there.
Hi, my name is Maria. I'm a new student here. I have a question especially for Professor Pate. I'm from Brazil, so we have a culture, or starting to have a culture of breaking patents of general medicines. During COVID, we also started trying to have a conversation of breaking patents for vaccines during pandemics. Do you think that this would be something that we should advocate for as public health specialists, or do you think this is a shot in our own foot, because then we would create the same issue we are having with AMR, that the companies would just not have any interest in producing if they don't have money?
I think we have to look at the mix of both sort of voluntary and involuntary incentives as appropriate for emergency things. For vaccines, is the patent the main thing? Or is it something else? I think you'll find that there are several other elements that go into producing a vaccine. And in the time of emergency, those were the issues. So I am not sure I think the issue of IP rights, I think one has to look at them, that there may be sort of incentives. So there's a proposal early in the pandemic stage to adapt the medicine patent pool idea for vaccines. It didn't get the light of the day, whereby there's a pool of funds whereby the IP holders will be compensated for the royalty. In exchange, they do voluntary licensing for manufacturers that can use their platform to produce. That requires tens of twenties of billions of dollars, but given the cost of COVID, 5% of global GDP at some point, multiple trillions of dollars globally, is it worth it? I would say it's worth it to actually have that compensation where they have incentive to produce, to innovate, and to get rewarded for that, but that you have the commons benefit in terms of manufacturing and making the product accessible to all. So it's not either or, it's sort of really finding where the public mission is and also sort of the private interest being compensated appropriately.
Right, yeah, sorry, Jessica?
Yes, okay, Daniel Wickler, this question is to Richard. Is it accurate to rephrase your complaint against COVAX that they over-allocated to sub-Saharan Africa? If COVAX had taken the age of populations into account, would you still be critical?
Did everybody hear the question?
No.
Okay, the question was, am I critical of the COVAX because they have overpromised sub-Saharan Africa, over-allocated, and is that my complaint? My complaint is not so much any one part of the world. I don't want to necessarily focus on sub-Saharan Africa. I use this as an example of an area which had extremely low mortality and yet was assigned a large amount of vaccine. It could be different in different areas. It would be like, let us say we had decided that Ebola was a global problem, and we decided that we were going to allocate, we're going to give 5% or 2% of the global population Ebola vaccine because of the mortality that was coming out of West Africa or DRC and what have you. To give the United States 2% or 1% or any percent would be absurd because Ebola was not going to be an issue in this country. And so why would you do? I would give it to the places that required it the most at that time, which would of course been parts of West Africa, so on and so on. Maybe Ebola is the best example, but there are other examples. Cholera, for example, cholera vaccine. You give it where the problem is, not with some formula that says all the countries of this particular region should get it. Take cholera in the Caribbean. Haiti had a terrible problem with cholera. Dominican Republic had no problem. Cuba had no problem because the water and sanitation in these countries was up to the mark. And so cholera was not going to spread there. So to give them a certain allocation based on their location to me would not have made any sense. I think that a lot of that's why I argue that a lot of the shortages, a lot of the problems that we had was because we tended to use a formulaic approach to the allocation. And many of these deficiencies and shortages were in fact created by the very system that we set up. That's my take.
Did you?
Yeah, I would say if Ebola was a global pandemic, the way that we've seen with COVID, I think US will take 3% or more. Even given they'll take more.
Everybody.
Yeah, they'll take everybody. So I think the public health goal that we're trying to accomplish, the epidemiology of the pathogen that we're trying to deal with, the product profile of what tool we're using should all be factored in adapting within the country how we deploy the vaccines. But to do that with some guiding principles for access for countries in the world when you have a global crisis. Marburg is just creeping around the corner, Ebola, God knows, flu. We have to be able to adapt, but within set global principles. I think that's sort of the idea. It's not prescriptive. But there's the issue of sort of the delivery, the absorptive capacity. But at least let's not have a world where you've got a social apartheid in public health, where it's sort of one track for folks and then some others will just get the vaccine in 3 years' time because they can't afford it. That would be a very sad world to be in.
Yes. I think we have time for one more question. Yes.
Yes, thank you. I'm Nancy Learn. I'm an epidemiologist on COVID and flu back in Hong Kong. And so one of the discussion that we had during the time is that there are innovative way of making like per dose of vaccines to be more valuable, like dose sparing or like even for like expiring vaccines, but like which are official shelf life actually can still work. So I wonder that like would we consider having this innovative approach of using those vaccines more effectively in COVAX, which that could be ethical issues in terms of why you have a higher standards for its use in wealthier country and in other, but would this be possible to kind of expand the vaccines available for country completely?
So you saw some of that with the vaccine donation effort, with COVAX managed, and some countries went bilaterally and donated. And this paper that I mentioned, I circulated, actually looked at those kinds of donations and to what extent, in fact, they work. I think, again, it's all goes back to behaviors of countries, of all of us really in these global commons. The just simple issue, let me give an example of the stringent regulatory authorities approval. You could have one way whereby you regulate it such that certain markets get the best quality, and at some point you may have the sort of lesser quality being regulated in a way that other countries get it. That would be not ideal. So a global mechanism like COVAX could help arbitrate so that there's a pool and in a way you manage that there are no extremes. There will be some of those tendencies anyway, but for the donations that have been done through COVAX, at least there was a mechanism and to target them to those who need it most, rather than just on the whims of countries who are willing to donate them or their convenience. I think it worked from what I gather.
I agree. I mean, we see this with drugs, by the way. The generic manufacturers, sort of mentioned India again in this, but that's in fact where a lot of the generic drug manufacturers are. There's a clear designation as to who gets what drug based on the quality and based on the ability of the company to test the drugs. This is a well-known and it's been well documented. So that country A, which let's say they're sending the generic drug to the United States and we have testing facilities, that's where the top quality goes. To some place which doesn't have the ability to, these are private companies, that doesn't have the ability to test, they get a different quality. So that clearly already takes place. And to set up an international standard, of course, would be a very good thing.
Well, thank you very much to both of our speakers, and thank you for. You clearly still many questions to answer, so lots of research to be done by everybody in the room. Thank